Hello, I'm Dr. David Ilson from Memorial Sloan Kettering Cancer Center. I'm here with Dr. Axel Grothe from the Mayo Clinic in Rochester, Minnesota. We are hosting the Great Debates and Updates in GI Malignancies 2015, and we're here to present the best of the day topic summaries.
Yeah, we had a lot of fun actually, debating certain hot topics, but getting interesting updates. And I think we started out strong yesterday morning by talking about colorectal cancer controversies in terms of, best frontline therapy. Recent data, large phase 3 trials, one from Germany, one from the US, kind of highlighted the idea that we have treatment options in frontline treatment for RAS wild-type tumors, and we'll come to biomarkers hopefully at some point. We can either use chemotherapy plus cetuximab or bevacizumab, as frontline treatment. I think that's the consensus we see out of the two trials. There's not any evidence that one particular treatment approach is better in terms of overall survival, progression-free survival is better. There's probably some higher response rate with the use of EGF receptor antibodies in frontline treatment, but in a palliative setting, we really don't know exactly what response rate really means. So I think it's good for us to see, as physicians, we have treatment options in frontline colorectal cancer.
Yeah, I think there were really contrasting conclusions from the European studies, the FIRE3, comparing FOLFIRI with either bevacizumab or cetuximab, suggested a late survival benefit for cetuximab.
Which is unexplained. I mean,
really unexplained, but the trial really wasn't powered for survival. And the fact that the survival benefit occurred very late suggested that it was probably more a function of second and third line treatment. But the US trial, CLGB 80405, which was really powered for survival, showed no difference, and I think reinforced that we have two options in RAS wild-type patients, either the use of EGFR-targeted agents or bevacizumab, but perhaps the toxicity profile favors initial use of bevacizumab to avoid the skin rash.
I think what both trials also showed, very importantly, and I think this is our consensus, we need to test for all RAS, NRAS, KRAS, exon 2, 3, 4, before we really commit a patient to treatment with EGF receptor antibodies.
Yeah, I think the uptake of that has been a little faster in Europe because the initial label for EGFR drugs was to test for KRAS mutations, but we know now that in the RAS wild-type patients, another 15 to 18% are going to harbor other RAS mutations, and that they are also equally resistant to EGFR-targeted therapies. And now the practice should be testing of all RAS mutations, which actually then brings us up to the next topic, which is we're now advocating also for testing for BRAF mutations as part of molecular profiling.
And not just because BRAF mutant tumors have a poor prognosis, because what would you do with a patient sitting in front of you where you know this might be a patient who only lives a year compared to, let's say, 3 years, which we nowadays almost anticipate or expect in other patients. But we do have treatment options now. We have trials, actually a national trial from the cooperative group system, which combines a BRAF inhibitor with an EGF receptor inhibitor and chemotherapy. And there are various other companies that are sponsoring clinical trials for this patient population need BRAF mutant tumors.
Yeah, it's interesting that it seems that BRAF inhibitors in and of themselves have little impact because there appears to be feedback activation of the EGF receptor, so that combining an EGFR inhibitor with a BRAF inhibitor is showing very promising results, and now even looking at adding other pathway inhibitors such as Mek inhibitors may play a role. In terms of the non-protocol setting, however, there was a debate outside of a study, because there are provocative data from the TRIBE study from Italy, suggesting that in BRAF mutant patients that it might be best to consider FOLFOXIRI, a triplet regimen plus bevacizumab with trends towards better outcome in those patients. So we may, outside of a protocol setting, have a preferred therapy option to consider.
And it makes sense in the way that we know that patients benefit from being exposed to all active agents. And the problem with BRAF mutant tumors, they progress so fast, that patients might not have, or likely not have, an ability to really move from first line to second line to third line. So giving them the chance to really get exposed to all active agents, I think makes sense. What I was intrigued about was today, actually, the novel circulating biomarker discussion. Circulating tumor DNA is a buzzword, and we've talked about this for several years, but I think now we see the first clinical data in various scenarios, like markers of minimal residual disease, looking at the circulating tumor DNA as markers of secondary resistance, after RAS mutations, for instance, appear after EGF receptor-based therapy. And I think this is opens the door for a lot of things we're going to do in the future.
Yeah, I think it allows really easy access to what's a reflection of what's going on in the cancer status for the patient. But and the advantage over a biopsy is that because you're looking at circulating tumor DNA, you're sampling essentially many different tumor cell populations rather than a single biopsy. So I think it's utilization for early detection, for screening after surgery, for monitoring patients on adjuvant treatment,
Correct.
and then potentially reassessing patients during the course of therapy to see whether new mutations develop. I think it's a very, very exciting area of technology. And then we also debated the relative merits of some of the newer salvage agents, such as regorafenib and TAS-102.
Yep. I mean, TAS-102 is the new kid on the block, hopefully this year, which is an oral fluorothymidine. So it's similar, it's kind of related to 5-FU. It was actually synthesized by the same pharmacist who actually gave us 5-FU in 1962, and I know that because that's when I was born. So I remember that, but the fluorothymidine as an oral formulation has shown proof of efficacy in a phase 3 study in salvage therapy setting in heavily pre-treated patients. Data, I think outcomes data, very similar to regorafenib in a last line setting. The PFS curves are completely superimposable, but what we see is that TAS-102 has a better toxicity profile, at least subjective toxicity profile, no hand-foot syndrome, really minimal diarrhea, mainly neutropenia, asymptomatic neutropenia. So it would be interesting to see what we do when we have TAS-102 and regorafenib as single-agent salvage therapy options at hand, what sequence we'll use.
Yeah, I think you made the point that now that we may have two potential viable late-line therapy options, that the sequencing might favor TAS-102, might favor regorafenib first because it's a little more toxic. It might be more appropriate for patients earlier on in treatment, and that the TAS-102 may represent an option for later therapy. Yeah. And also, I think the activity of regorafenib emphasizes the issue of continuous VEGF suppression during various lines of treatment, that we get benefits first line, second line, and late line. That continuous VEGF suppression seems to convey benefits for patients throughout the course of their treatment. Yeah.
And I mean, the point concerning regorafenib that you already alluded to is, I don't think patients who are too far down the road, in terms of their deterioration of performance status, are appropriate candidates for regorafenib. I think we need to be very careful, make a judgment call. Not every patient with colorectal cancer with deteriorated performance status really needs regorafenib.
Yeah, and then there was a discussion about appropriate dosing, perhaps starting at a lower dose level or alternative schedules which are being pursued in clinical trials. Yeah. We had a very vigorous discussion about the optimal treatment of rectal cancer, including discussions about standard preoperative therapy, which would be capecitabine or infusional 5-FU radiation followed by surgery. That certainly now for T3 node positive tumor, preoperative chemoradiation has become the de facto standard. Very interesting research data suggesting that in a research setting, the use of preoperative chemotherapy alone with a regimen like FOLFOX, and patients that have a vigorous response and go to surgery, that we may selectively avoid radiation in those patients and only apply radiation to patients with little response that might greater benefit from it.
Yeah. I think it's interesting, the field of rectal cancer is clearly changing. For a long time, we just embraced the German standard protocol, chemoradiation therapy, over protracted 5.5 weeks with the delayed surgery then. But now we have options. I mean, beyond just using chemotherapy, we're looking at short course radiation therapy, for instance, 5x5 grade with immediate surgery, which kind of is probably appropriate also for patients with M1 metastatic disease with curative intent. We have had a discussion, we saw data on a non-surgical approach. So you mentioned, not using radiation therapy in these patients, but if you have a complete response, a clinical complete response, can you save the sphincter? Can you say by not doing surgery at all? And I think this is also very interesting.
Yeah, I think appropriate patients with a little bit earlier stage disease from the onset that appear to achieve a clinical complete response that are followed very carefully, that a subset can be followed expectantly with the knowledge of about a 30% local failure rate at about a year. Yep. But certainly the idea in very selected patients about the selective avoidance of surgery is a consideration.
Yeah, but I think that is probably for patients' perspective the single most important topic that you and I talk about when we discuss rectal cancer, lower lying rectal cancers, for instance. And so I don't think we'll ever have randomized clinical trials, because it's very difficult to randomize tool. It's in APR versus no APR. But it's important to really conduct these cohort studies, like at Memorial, like in Sao Paulo in Brazil, very carefully, and give us guidance. How should we monitor these patients? Because that's critical.
But of course, one of the key worries about deferring surgery is these patients need long follow-up. Because what a lot of these conservative observation series show is late recurrences. So that following patients for 5 or even 10 years may not be enough to really adjudicate whether this is an appropriate approach.
But we see these late recurrences even with resected tumors.
Yes.
There's still, even with good quality TME resection, there's still a risk of recurrence, and sometimes even delayed recurrence, as you said.
Yeah, we debated a little bit the controversy about chemotherapy and rectal cancers. Some of the earlier European pooled analyses showing no clear benefit for adjuvant chemotherapy, mostly 5FU, that maybe colon cancer and rectal cancer are different. And we argued that perhaps because many stage 2 patients are treated in these rectal cancer studies, it might have undervalued the benefit of chemotherapy. But that still the standard of care at the end of the day for a node-positive rectal cancer remains adjuvant FOLFOX.
But you bring up a good point for node-positive rectal cancer, and that's what you and I would probably agree on. We model our adjuvant treatment decisions according to what we do in colon cancer, and the important point is the clinical stage before neoadjuvant treatment, because it really drives the decision. But the NCCN guidelines really recommend, regardless of nodal status, recommend FOLFOX as preferred regimen. I think it's over-treatment in a lot of patients.
Yeah, I think for a T3N0, it's arguable, but remember, you don't want to use the pathologic stage because the patients are downstaged. If they had pre-treatment T3N2 disease and they're T1N0, that doesn't mean that they're now, their pre-therapy stage is stage 1. And then we also discussed the interesting data regarding the preventive use of aspirin. Many practitioners will give a baby aspirin routinely based on the pooled analysis data showing some survival benefits. Whether biomarkers are available to identify patients that may benefit more from aspirin preventive therapy is really a work in progress.
Yeah, there are some controversies about exactly the biomarker issue. I think we all agree that aspirin does prevent or can help prevent a certain subset of colon cancers. We have not yet identified exactly which cancers can be prevented and whether we have let's say, pharmacogenomic biomarker, like your normal tissue, or a tumor tissue biomarker. It's going to be interesting to see.
Yeah, and in particular, the recent data for Lynch families, where it's probably almost obligatory to put those gene carriers on aspirin, where you see significant cancer reduction risk over long-term follow-up. We also had an interesting update on immunotherapy and GI cancers. That's clearly an area that's moving forward, certainly potentially targeting the colon cancer subsets, these microsatellite instability, high patients that have a lot of mutations and antigen presentations, so they're very immunogenic, that this is probably going to be the ideal subset in colon cancer to study immunotherapies, as well as very encouraging data in gastric cancer for some of the PD-1, PD-L1 therapies. These drugs are now moving into randomized phase 2, even phase 3 trials in all lines of therapy. So we're going to hear a lot about earlier line use of immunotherapies in these diseases.
And I'm actually encouraged I think we're doing the right thing in developing appropriate biomarkers. You talked about the hypermutated MSI-high tumors, looking at PD-L1 expression levels, for instance. I think, for immunotherapy, because we know not every patient will respond. I mean, we response rate in gastric cancer, somewhere between 20 to 30%, whoever looks at the scan. So there is a subset of patients that responds. And I think the studies that are being conducted right now are savvy enough about these issues that we will find good answers in terms of biomarker selection.
Yeah, I think they're going to have to be validated because we certainly even know in the diseases where the treatments are further along in development that even patients without, let's say, without PD-L1 overexpression have some benefit from therapy.
It's not a qualitative marker, yes or no. It's a quantitative marker. You have a higher likelihood of benefit, at least with the markers we have right now.
Yeah, and then we had an ongoing debate about, in esophagogastric cancer, the optimal treatments. For esophagus and GE junction cancers, that we have two therapeutic options: preoperative chemotherapy, combined chemoradiation are viable options. That an emerging consensus that perhaps for the esophagus and GE junction tumors we do get better local control and less local recurrences, that radiation may play more of a role. However, in gastric cancer, which is more distal, the data sets raise more of a question of whether radiation therapy is really required in the adjuvant management of gastric cancer.
Yeah, I mean, I think this is a shift that had a long coming, you know, and we base our adjuvant radiochemotherapy data on the intergroup trial, which was published almost 15 years ago now. I think since then we've optimized, we have better systemic chemotherapy, and I think some of the data coming out of Asia with, let's say, oxaliplatin-based adjuvant treatment approach, fluoropyrimidine and oxaliplatin, I think they deserve to be rightly considered as one of the standards of care. And I think you have to make a case whether or not a patient really needs radiation therapy. It could be a subset that benefits in adjuvant setting gastric cancer, but I think most patients will benefit from chemotherapy.
Yeah, and that really the need for radiation in gastric cancer is largely a function of the adequacy of the surgery.
Absolutely.
That patients that have D2 resections, which is really the academic standard, have much lower rates of local recurrence, that radiation plays less of a role, whereas patients that may have less optimal surgery, less than a D1 resection, that was actually the McDonald 5FU radiation population that showed a benefit with local recurrence reduction. And now we're seeing the emergence in esophagogastric cancer of second-line therapies.
I mean, we've known for quite some time that second-line chemotherapy has survival benefit. There are several studies that looked at taxanes or irinotecan versus best supportive care. Smaller studies, not, let's say, larger phase 3 studies, but very kind of consistent results. You know, there is a role for second-line therapy in the appropriate patient. And now the idea is, you know, can we improve upon, you know, just chemotherapy? We have a targeted agent, you know, or kind of a biologic agent, because I don't believe that VEGF inhibitors are really very targeted. They interact with the tumor host microenvironment. So we have ramucirumab as a VEGF receptor 2 antibody that has shown survival benefit in second-line gastric cancer, single agent and in combination with paclitaxel. The discussion that you actually had with Harry Yoon was, is it worthwhile? Is there enough value to do that? And it was an interesting discussion, actually.
Well, I think most clinically relevant for practitioners probably would be the combination of ramucirumab with paclitaxel, because most patients are going to be candidates for likely combination treatment because you saw benefits in response rate as well, in addition to progression-free and overall survival, with really very little added toxicity.
Except for the financial toxicity.
Well, I mean, that's a separate discussion, but we have to remember that in colon cancer, all these little incremental benefits, when you add them up, you start getting translation into survivorships of 3 years. So I think we're going to slowly see this in esophagogastric cancer, that we're pushing the boundaries of survival out, and that the validation of VEGF as a target in esophagogastric cancer is going to lead to the exploration of other agents, combinations of ramucirumab with other drugs, as well as a full vetting of ramucirumab in first-line therapy, which is going to be the subject of the upcoming Rainfall study.
Yeah. Now, we had discussions about the other biologic agent in gastric cancer, which is trastuzumab, which is very well established. I think no one doubts anymore. I mean, that this should be clearly part of our repertoire. Question that we discussed was should we continue it into second-line therapy? What's the combination partner in second line? And I think the consensus was, in spite of the absence of data, most of us will do this, using trastuzumab beyond progression, in analogy what's being done in breast cancer. And there's a lot of drug development following the breast cancer model, pertuzumab, TDM1, et cetera. We'll see a lot of data come out next years.
Yeah, I think we're going to hear results, hopefully upcoming, about first-line use of dual-targeted HER2 therapy with pertuzumab, trastuzumab, and chemotherapy. And in the second line, in trastuzumab refractory patients, TDM1 versus chemotherapy will be studied. We then had an excellent overview of the management of neuroendocrine tumors, some of the emerging new somatostatin analog drugs that are now approved, including lanreotide as an alternative to octreotide, and targeted agents like sunitinib and everolimus.
I mean, the issue that I think for clinical practice, which we discussed after the presentation, was when do you start octreotide? And is it in the carcinoid patient, where you have smoldering disease? I mean, we have the PROMID data, which are suggesting, everyone should be treated with octreotide. And I think the consensus amongst the discussants was, since this is such an indolent tumor in a lot of patients, there's no need to rush for using octreotide right away. So in my clinical practice, and I know that's in your clinical practice too, I observe what the growth kinetic is, and then I use this somatostatin analog, selectively at the right time point.
Yeah, obviously in patients with functional tumors, with hormone-active disease, we're going to start them right away. But in patients with non-functioning tumors, they can sometimes be observed closely, even for a period of years, before therapy is introduced. Now we have increasing options in pancreatic cancer. We now have 2 standard combination regimens that have improved survival over gemcitabine alone in metastatic disease. We have FOLFIRINOX.
Was a low bar.
And gemcitabine and Abraxane, but certainly the FOLFIRINOX, a rather significant advance. Gemabraxane also. Survival improvements, response rate benefits over gemcitabine alone. And we're going to debate whether or not these regimens should be applied in the adjuvant setting. Right now, the standard of care would be gemcitabine for 6 months after pancreatic surgery. We can argue the debate of radiation, whether it's really required, and certainly whether or not these newer regimens will be validated in ongoing phase 3 trials in the adjuvant setting, we'll have to wait and see what the data show.
Yeah. I think it's also interesting we're talking about drug development in second-line therapy in pancreas cancer, which about 10 years ago no one would have anticipated that we'll do that, because at that time we were running gemcitabine plus minus a certain agent du jour. Yeah. But now we have data, actually survival benefit data, new irinotecan-like agents. For instance, irinotecan, I think, has made a comeback in pancreas cancer. We know it's active.
Yeah, the liposome encapsulated irinotecan achieves survival benefits in second line. It's on track to potentially get approval as a standard second-line option in refractory disease.
JAK inhibitor, interestingly, ruxolitinib in the CRP-positive tumors, anti-inflammatory marker, anti-cachexia marker. I think it's very interesting.
Yeah, well, because these JAK-targeted drugs may have roles in the inflammation, the trials are now enriching for these patients with biomarkers like CRP, and that this subset may benefit from JAK-directed inhibitors combined with chemotherapy, and we await the results of ongoing randomized trials.
Yeah. And immunotherapies in combination with vaccines are being tested too. I mean, pancreas cancer is now a field for drug development, which I thought was interesting, how one switch in standard of care, making this tumor a treatable cancer with response rates which are more presentable, really changed the approach we use in drug development.
Yeah, well, I think with a more active chemotherapy backbone, with gemcitabine, you had survival measured in 6 months, medians, and now we're extending the bar out to almost a year with combination regimens, and hopefully we'll move forward with targeted therapies, but as of yet, really no clear leads and a number of negative studies, which has been disappointing. And then, I guess to close out our discussion, hepatocellular cancers, certainly with the advent of sorafenib as an approved targeted agent with survival benefits in this disease. What's been frustrating is the litany of randomized trials that have compared sorafenib with other drugs or sorafenib combinations that show no benefit. And then in second-line therapy, we've not been able to identify an active agent that's better than best supportive care.
Yeah.
So very frustrating, and also a field clearly in need of vigorous biomarkers to select patients for newer targeted therapies.
It's interesting. When I look at HCC and I compare it to pancreas cancer, you know, we're kind of locked into sorafenib like we were with gemcitabine, and nothing has beaten sorafenib yet. Actually, it's an active agent, but it failed in the adjuvant setting. It failed completely in a large trial in the adjuvant setting. So it's another proof of principle that we have never had a VEGF inhibitor in any disease in human malignancy that showed benefit in adjuvant setting, which I think, even though we have some data in a palliative setting.
Yeah, so it also didn't seem to impact on ablative strategies. Combining sorafenib with TACE didn't improve outcome. But again, I think there's some interest in some newer targets like MET-directed therapies. There are a couple of tyrosine kinase inhibitors in development, such as cabozantinib, and tivantinib are now in randomized phase 3 trials to see, in second line, see whether we can move the bar forward.
Which is not an easy patient population. Second line HCC with such high dynamic of deterioration of patients, liver dysfunction, I mean, it's not easy.
Well, even in first line, one could argue that the use of sorafenib is really reserved for the Child's A patients.
Correct.
With much limited benefit, less, if any, benefit from Child's B or C.
Yeah.
And then how do we manage locally advanced hepatocellular cancer? Surgical strategies, ablative strategies, this is an ongoing area of debate as well. And we have certainly options to offer patients, including liver resection, transplant in the setting of indication for liver transplant, such as cirrhosis and hepatic failure. But an interesting debate that we're going to have later today, where we have the interventional radiologist squaring off with the surgeon to argue what's better for a locally advanced hepatocellular cancer, and we'll see what that shows.
No, it's always been fun. This is a great meeting. It's actually my favorite meeting because we debate a lot. It's a great venue, New York, your home, your place, and we're already planning next year's great debate.
Okay, terrific.
Okay.
Thanks very much.
Thank you.